From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello to everyone. My name is Deborah Grady. I'm a professor of medicine at the University of California in San Francisco and a deputy editor of JAMA Internal Medicine. We're here today to discuss a study titled Time-Limited Trials Among Critically Ill Patients with Advanced Medical Illness to Reduce Non-Beneficial Intensive Care Unit Treatments. The manuscript presenting the results of this study is published in JAMA Internal Medicine. I'm really pleased to discuss this study because I think it provides important evidence on the use of time-limited trials in the ICU that could be clinically important. I'm happy to be joined today by the senior author of this study, Dr. Dong Chang, who's associate professor in the Division of Pulmonary and Critical Care Medicine at Harbor UCLA Medical Center and the David Geffen UCLA School of Medicine. He's also director of the Medical Respiratory ICU at Harbor UCLA. I'm also joined today by the author of the commentary that also published today that accompanies this study, Dr. James Tulsky, who's chair of the Department of Psychosocial Oncology and Palliative Care at the Dana-Farber Cancer Institute at Harvard. So welcome to both of you. Thank you very much for joining us today. I'd kind of like to start out by asking each of you to just tell us a little bit about your background and how you got to your interest in ICU care and time-limited trials. Dr. Chang, maybe you could go first.
Sure. Thank you very much for the invitation. Really appreciate the opportunity to chat with you today. As you mentioned, I am a medical ICU director at one of the large public hospitals in Los Angeles. And one of the first things that drove me to study non-beneficial ICU treatments and really our healthcare utilization in the ICU is the recognition that when I first joined as an ICU director, what struck me was that so much of our ICU care delivery was really to patients that, when we closely examine them, would be at risk for receiving a lot of invasive treatments that they might not benefit from. So we conducted a series of data collection and studies that tried to quantify that. And then this study, which tries to intervene on that process, is a natural extension of that. So my research interests are in health services research, primarily along those lines.
And Dr. Tulsky, what about you?
Well, thank you very much for being here. So ever since I can remember, I've been most interested in medicine and how we speak to each other. And that becomes particularly pressing when people are seriously ill or toward the end of their life. And so it was many, many years ago, before, in fact, really palliative care was even a field. And I was a resident, actually, where you are, Dr. Grady, at UCSF. And I just noticed that how we spoke to our patients about decisions toward the end of life, specifically do not resuscitate orders, didn't seem to meet the goals of what we were really trying to get at. And so I began audio recording conversations between doctors and patients, discussing DNR during cancer care, during intensive care, and became particularly interested in, what were the nuances of what we did and what we said that actually could improve the likelihood of outcomes that helped patients meet their goals. And so I've been doing that sort of work ever since, and it led me into palliative care.
Great. Dr. Chang, would you just describe for us a little bit the problem that the study was designed to address? I mean, what's the clinical issue here?
Yes, sure. So the larger clinical issue is, as I briefly mentioned, that a lot of our ICU treatments, invasive ICU treatments, are frequently overutilized. And so, fortunately, we have the benefit in the ICU of delivering a lot of our treatments to patients that will benefit, that will recover. But unfortunately, it's also a very common occurrence that invasive ICU treatments are delivered to people who probably would not benefit from them. And that's for a multitude of reasons. It may be underlying medical conditions or the severity of their illness. And in those situations, we oftentimes prolong suffering without significant benefit. And when one really tries to break down why that's happening, one of the common themes is poor communication that occurs between patients and surrogate decision makers and clinicians. And so the larger issue there was that we wanted to try to address some of that poor communication and care planning as well.
So essentially, we're talking about invasive procedures like mechanical ventilation, renal replacement therapy, pressors, and that sort of thing.
Those are all great examples, yes.
Yeah, in very sick patients. Okay. And Dr. Tulsky, do you want to describe the problem from your point of view?
Sure. I think the issue is that these patients are in intensive care, and the patients, if they're able to communicate, and certainly their families and surrogates, are generally hoping for them to get better. And they're usually hoping against all odds and will frequently take a tremendous amount of risk to get there. At the same time, you have a clinical team that is watching the course of care, oftentimes becoming increasingly pessimistic about the possibility of these sorts of interventions helping. And the two sides tend to get quite frustrated with each other. And I so often see conflict actually arising in intensive care units because the teams don't think that there's a possibility for things to get better, repeatedly address this concern with families. Families feel that they're being given up upon. And there's no really shared language to be able to advance what's happening. And so, therefore, I think regular family meetings with high quality communication are key. And that's something that we always advocate. And there have been a number of studies and interventions looking to try to do that. What I think happened in this study in terms of using the time limited trial as a mechanism around which to organize that conversation takes us even one step further.
Well, let's jump into the study itself. So, Dr. Chang, can you just give us a high level overview of the study design and the main findings, just to orient our listeners? We'll come back to some of the details of this later.
Sure. So our study was a before and after study of a quality improvement intervention that was conducted in the medical ICUs of the 3 public hospitals in Los Angeles. And the intervention was basically to train ICU care providers to communicate and plan ICU care using a time-limited trial format, which we could discuss a little bit more. And the patients were those with advanced medical illnesses that were at very high risk for potentially non-beneficial treatments. And really what we found was that after this intervention, family meetings, the quality of the family meetings improved, meaning that they occurred more frequently, they occurred earlier in the hospitalization, and the content that one would need in family meetings to really facilitate shared decision making was more prevalent. And then in addition, we saw changes in ICU utilization, including a decrease in the ICU length of stay and hospital length of stay, as well as a number of procedures, including mechanical ventilation and the use of central venous catheters and so forth. And despite this lower intensity of ICU treatments, what we found was no change in mortality. So those were some of the main findings.
Well, okay, just can you explain to me what exactly is a time-limited trial and, how does it work? Let's say, for example, that my father is really severely ill and he's in your ICU. How would you talk to me and to my family about a time-limited trial?
Sure. Well, a time limited trial is basically an agreement between clinicians, patients, or in our patient population, more often the surrogate decision makers, to use certain medical interventions that are typically very invasive, like mechanical ventilation, for a defined period of time, and to really carefully assess whether that treatment is providing clinical benefit using agreed upon clinical parameters. So, using parameters that logically predict whether someone would do well after mechanical ventilation would be things like oxygenation and so forth. And then follow up meetings are scheduled to really look at that data together, put that in the context of what the patient's values and preferences would be, and then discuss next steps based on how things are going. And what we think this does is it really creates opportunities to understand each other better, as Dr. Tulsky mentioned, to share medical information, to discuss prognosis and understand values and preferences. And it really allows a little bit of time for emotional adjustment, which we think is very important. And it allows everyone to feel like all indicated treatments have been pursued before making potentially more difficult decisions, such as transitioning to comfort-focused care.
So if my father was, had acute respiratory distress and looked like he was needed to be intubated, your team might suggest a time-limited trial of mechanical ventilation for how long? Are we usually talking a couple of days or a week or what?
Yeah, that's a tricky question, and it really depends on the clinical situation. But for instance, I think for respiratory failure, it would be very reasonable to consider about 48 to 72 hours. It would really depend on the clinical condition, the trajectory of the clinical events that are going on. Some patients are more rapidly deteriorating than others. So it would depend on that, but those would be typical timeframes.
And so then you'd kind of agree with me and my family that if something happen? Like his oxygenation got better, we'd continue, but if it got worse or he needed pressors or something like that, that we might decide together to stop?
Yeah, that's correct. And so the follow up meetings are usually centered around discussing everything, the relevant information that we've seen for the last 48 to 72 hours, for example, and then really discussing the implications of all of that, trying to put into context how the patient would feel if they were able to communicate with us in terms of how they would feel about potential outcomes, the most likely outcomes, and so forth. And also allowing the family to feel that it's okay, that it sometimes is a loving act to be able to transition to comfort focused care and minimize prolonged suffering and things like that.
So, Dr. Tulsky, have time limited trials been used before? I mean, do you think the approach used in the study was different?
Time limited trials have been used in ICU care and, for that matter, other kinds of care. I work in a cancer institute, and we use them all the time around cancer directed therapies and saying, we'll try this therapy, see whether or not it makes a difference in disease progression. And if not, then we may, switch off or perhaps stop such therapy. So these kinds of things have been used in practice forever. What's different here is that, as far as I can tell, and we reviewed this when we wrote the commentary, no other study has really introduced it into a trial in the way that it went here. And so we've never formally studied whether it can make a difference. So in that sense, it's new.
So I guess doing this, one of the natural effects of doing this is that you have to meet with the family on a very regular basis to assess, whether there's been progress or not. And that probably promotes regular family meetings and better discussion. Is that right, Dr. Tulsky?
Exactly. I think that this is another piece that's a bit unique here in this trial, is the idea that these are decisions that are made over time. And it's longitudinal care. And it's not a one shot, you have one family meeting and you make a decision at one point in time. This evolves. It evolves because what Dr. Chang said, which is that the families need to accommodate emotionally to what's going on. They need to begin to see the course unfold. They also have to begin to grieve the loss. And it also takes time because we don't know necessarily whether the intervention is going to work. So that's a big difference, to be able to think about this as not just one conversation, but really points in time and with measurable outcomes that can help you know whether or not you're actually being successful in what you're trying to do.
So let's talk a little bit about the design of the study. Dr. Chang, can you tell me a little bit about how the participants were selected? There, of course, a lot of people come through the ICU and not all of them are sick enough to need invasive care. Who were the participants in the study and how were they selected? I know that when we were reviewing your article, we were a little worried that maybe for some reason patients who were less sick were selected after the intervention than before the intervention. Can you reassure us that that didn't happen?
Sure. So we struggled with this quite a bit, as you can imagine. What we really tried to understand was how could we make the selection of patients match what's going on clinically, because I think that has the best application. And so it's hard to really quantify well, why is somebody potentially non-beneficial in terms of ICU treatments. And so what we decided to do was use the guidelines that are produced by the Society of Critical Care Medicine that categorize patients into the likelihood of benefit on ICU admission. And there are multiple categories, but one of them, essentially summarized, is that the patient needs critical care, but the underlying medical conditions in which they have or the severity of illness would make it extremely unlikely that they would benefit in the long term. And so that was the general criteria that we used and trained physicians to think about in terms of selecting participants. In addition, we were at 3 different hospitals that had patient populations that were slightly different, and the ICU directors and the champions of our study at each of the hospitals were very good about selecting and creating examples of the types of cases that might be considered. I think you raise a really excellent point that this was a before and after study design. And so it's quite possible that participants that are selected could be different after an intervention that teaches physicians to talk about non-beneficial treatments in time-limited trials. And while that is a potential bias, we were reassured by the fact that the baseline characteristics of the before and after population were relatively similar. What we also found was that the enrollment of patients who physicians considered or at risk for non-beneficial treatments in the before and after group, the proportions were relatively similar as well, and the study results also were still present. The findings were still significant after multivariable adjustment. So those were some of the findings that would suggest that perhaps the bias wasn't as large of a role as we were originally concerned about.
And these patients were really sick. I can't remember exactly, but a large, very large proportion of them died, right?
Yeah, I think the mortality was a little over 50%.
Yeah, over 50%. So tell us why you chose to do a before-after study. Why not just do a regular old, randomized trial?
Yeah, it would have been far and away our preference to do a randomized trial. This is a group intervention, so the design would have probably needed to be a cluster randomized design, and of course, those are challenging in many different respects. I think there were considerations in regards to resources and the number of centers and so forth, but really, I think what it came down to was we needed to learn how to walk before we learn how to run, and so this is a complex healthcare intervention. We really needed to convince ourselves that we can appropriately train physicians to do things in this way, that we can really understand how much variability there is in different clusters of hospitals, that we could feel reassured that everything that we're doing allows us to make the appropriate measurements afterwards. And so this was, I think, an initial step, and we would certainly seek to try to conduct further studies that look at things a little bit more rigorously than a before and after study.
So, Dr. Tulsky, I mean, you've had a lot of experience with this sort of quality improvement, communication improvement research. Did you think this was a reasonable study design?
I think it was the only study design that was going to be doable in
Oh, the
this
only study
circumstance.
design. And that's more than reasonable.
Yeah, I think that. So I have conducted a number of clinical trials, and they are enormously difficult to do on large enough scale where, because the question is, at what point do you randomize, right? And it's very hard within any given institution to randomize the clinicians themselves because you're going to have so much contamination with the other groups. You would need to have an inordinate number of centers if you're going to be randomizing by center, and then you'd still be having to correct for some of the confounders there. And so I think it's really difficult. And what I've been finding is that we spend years to conduct that kind of a trial with just huge amounts of money, and we struggle, and then our data may not be that much better. I think there's a certain point with which we have to say they've done what they could. The data really looks fairly convincing. Conceptually, it makes a tremendous amount of sense. The risk of doing such an intervention is exceedingly low. So this is not like a drug trial where we might be missing that sort of thing. And so I think this was the right approach in a study like this.
So I'll also point out, I think the study was actually somewhat stronger than a very simple before-after study, where in most simple before-after studies, you make a measurement once, you introduce the intervention, and then you make the measurement again after the intervention. In this study, there were measurements made, I think Dr. Chang, was almost weekly, of things like length of stay in the ICU and length of stay in the hospital. So you were able to get a really stable pre-intervention estimate and then see a change when the intervention was instituted, and then a stable sort of improvement afterwards. This is more along the lines of an interrupted time series study, but I think that being able to do this also strengthened the results of your study and support the study design.
Yeah, that's absolutely correct. Thank you for mentioning that, Dr. Grady.
Well, let's talk a little bit more now about the likely benefit of this intervention. It seems like from your presentation, from your paper, that most of the benefit was in the patients who did not survive. Dr. Chang, can you describe the results in a little more detail, and both in the survivors compared to those who died?
Sure. So we basically had a pre-specified subgroup analysis that stratified based on survivors and non-survivors. And the idea there was that a time-limited trial would likely have its greatest effect in people that would not survive. And those that survived, I think what we would see is a series of meetings where we're able to deliver wonderful news that perhaps our patients are getting better, that we should continue with the ICU treatments. And any kind of discussion that we might have in terms of non-beneficial treatments or transitioning to comfort-focused approaches would generally occur in those who aren't responding and unlikely to survive their ICU stay. And that is what we saw in our study. I believe that our pre-intervention and post-intervention differences in our primary outcome, which is our ICU length of stay, was about maybe 2.5 or 3 days in the non-survivors and almost identical with no changes in the survivor cohort. And we saw very similar trends in the use of invasive procedures like mechanical ventilation and things as well. And the way that we interpreted this was that the time-limited trials are likely most effective in those that are unlikely to survive ICU stay because of their severity of illness.
So, Dr. Tulsky, is this also how you would interpret the results? Reducing the use of invasive, probably non-effective care in patients who are likely to die?
Yeah, I will preface it by saying that I am always a little bit uncomfortable in making a desired outcome being the use of less invasive treatment. I hope the ideal outcome would actually be goal concordant care. That wasn't actually measured in this study, which is, did the patients end up getting the care that they would have wanted or that met their values? And that's a hard thing to measure. I'm hoping that because of the number of family meetings and the ongoing communication that happened, that in fact that was true. And that also resulted in less use of what would have been non-beneficial treatments. I think that's a good thing. I do think that one thing that's interesting to point out is that the mortality rate in the study was, as mentioned before, a little bit over 50%. But that means that, 40-something percent of the patients survived, which means that expectations are not necessarily entirely unrealistic in these scenarios. And therefore, the time that almost gives more credence to the idea of using a time-limited trial. It's not just a way to sort of sneakily withdraw care. It's actually a way to really evaluate, what is likely to work in a particular patient, and then together with the patient or their family, figure out the best way forward.
Yeah, that's a really good point. It was kind of a 50-50 here. So, a good half of these really sick patients survived. And, we haven't talked very much about the outcome in terms of communication, like how often family meetings happened, how quickly they happened, and that sort of thing. Dr. Tulsky, maybe you want to, since this is your communication is really your area of expertise, you want to say a few words about that?
Sure. So what was found was that the family meetings, first of all, were more common. They went from, I think, about 60% in the pre-state to nearly 100% afterwards. So that in and of itself is good. We knew that there were more communications happening. And the meetings themselves were better in that they were more likely to include the various elements of communication that we would think are important and that were outlined in the article. So in that sense, I think the communication was better. I mean, we don't have direct observation of that. And the other thing is, the only thing that kind of began to look at that was or family member satisfaction, although those results were so high and didn't change between groups. So it's a little hard to know. So if I could add anything to this, although it would have been a much more difficult study to have done, it might have been to have been able to look and see what was actually being discussed.
How would you do that? By observing or recording or what?
Sure. I mean, by recording, most likely, we have the technology to be able to do that. And so, and we have ways of evaluating what the quality of that communication is in the actual conversations. That would be, the gold standard for how to look at that.
So, Dr. Chang, do you have anything to add to this issue of improved communication?
Yeah, absolutely. I think it's a tremendously important issue and one that, I will tell you one of the really interesting things about our intervention and our training was kind of this recognition that we had as we are going through it that perhaps the magic's not just in a time-limited trial. As Dr. Tulsky mentioned, it's a nice format for communication, but it's really improving that communication overall that I think drove the effects of the study. So, as an example, the training that we did involved using simulations with actors as family members and just seeing our clinicians involved with that process, but also understanding things like the importance of empathy, the importance of recognizing that in somebody who you're speaking with, validating that, dignifying some of these emotions, and then moving on to preferences and time-limited trials. It really drove a lot of what the feedback was in terms of why this was a well-accepted method of communication. And my personal feeling is that it really drove a lot of the results as well. So that the improvement of communication overall, in addition to just having a format like a time-limited trial, I think was very important for this study.
I'd like to end, I think, by asking both of you what you think should happen next. Are we at a point where other ICU teams should be introducing time-limited trials into their patient care procedures? If you think so, can they obtain the protocols and training materials that you used in this study? What do you think?
Yeah, I think that introducing time-limited trials into this conversation, into the classic ICU family meeting, is absolutely something that ought to become mainstream. And it's something that we've known in the past probably worked well. We now have data to show that, in fact, it does have positive outcomes. And I think that what it does is that it really helps us manage the uncertainty in these conversations. Normally, when you listen in on an ICU family meeting, the thing that you don't really hear talked about is the uncertainty, is the likelihood of one thing or the other. And there's no way to actually give tools to the team for how to manage that, which is what really everyone is struggling about. If people knew that something was going to absolutely go one way or the other, then they would be all in on either of those choices. It's because they just don't know. And so the time-limited trial gives a way through that. And I think together with shared prognostic awareness, with addressing the emotion of the family members and so forth, could take us a long way.
So, Dr. Chang, are you going to continue using this protocol for time-limited trials in the ICUs that you direct?
Yes, absolutely. I think it's been very effective for us. I will say that, as we think about scaling up and scaling out, I think some really important considerations are just understanding the role of environment and context in which the study occurred at our hospitals. These were training centers, these were clinicians that we all had relationships with as study investigators because it was our home court, it was our hospitals. And I think having that kind of understanding, really putting a little bit of thought into how one implements the training element of it, making sure that it's not just didactic, making sure that there's a learning and observation, actually using the words and using the protocol and getting feedback on that. As Dr. Tulsky and others have described in so many different ways, having some kind of really well-conducted program, I think, is really important if one were to incorporate this protocol.
Thanks very much to both of you for this discussion, which I think has been very interesting and really clinically important.
Thank you so much.
To our readers, let me just say you can get more of our JAMA podcasts by visiting us at jamanetworkaudio.com, and you can listen and follow wherever you get your podcasts.